So for asthma, we didn't look at it, but as you mentioned, there was a recent paper in JAMA published by some of my own colleagues at USC, which looked at that issue, especially for a pediatric population, and they do find that increase in cross-sharing is related with more inpatient episodes. So we didn't look at that in this population. On the use of preventive care, we were looking at subpopulations eligible. So I wasn't looking at use of colonoscopies for the entire population, but for the population for which this is recommended, so people over 50. And then similarly for mammograms, we were looking at the population for which they were recommended. And I agree with you that for some of the chronic disease medications that we are looking at, statins and antihypertensives, you're not going to see effects in 2 or 3 years. So that's why, we've highlighted that is a cause for concern. Like if I were implementing this, I would carve out those medications or have some other mechanism for making sure people understand that this is not a good idea. But we couldn't look at very specific subpopulations where you would see kind of immediate acute effects. That's partly because even though we have a lot of data, when you start looking at subpopulations, the sample sizes kind of reduce a lot, and we get a lot of statistical noise.
So, I guess my and I appreciate the limitation study, and I think I appreciate the work that you've done. I think when we look at the policy point of view, the things that I'm concerned about, and I know that your study at this point can't answer unless we follow a lot longer, is that I heard that hemoglobin A1C checks dropped, right? That's concerning because again, the result of that is you're going to have people with diabetes who have it's a cumulative effect over time, and you're going to have more neuropathy and so forth. You're not going to pick that up, the outcomes in the study, back to the outcomes part, but we certainly know, given the body of research we have on diabetes control, that some point later in time, whether they're this employer or they're somewhere else, that's going to be a healthcare cost that's going to go up, right? And the reason I wanted to ask specifically, looking at perhaps asthma and diabetes, was that just as examples of conditions where you would, within a 3-year time frame, perhaps be able to see are the trade-offs people are making about their chronic disease medications. Is this really going to lead to healthcare savings? Because as you mentioned, the reasons people got the healthcare savings, what I'm really worried about, and I think I mentioned in my introductory remarks, is that what happens is we're saving money now to increase our costs later on, costs both financially, costs in terms of health status. And I'm not sure that's a great trade-off that we want to promote. And as we're looking at things like retiree health costs, I'm just concerned about how that overall expands. And then certainly the other piece is that, of course, from the state's perspective, whether we have a high deductible health plan or not, how does that actually affect our overall state costs, as well as, of course, very importantly, the health of our employees and our retirees? So is that going to all come out in the wash between these different subsidies and so forth? So yes, maybe for a short period of time, but we're actually going to, over the long term, actually find ourselves with a greater burden, both health-wise and cost-wise. And I realize your study can't quite answer that, but I was hoping that if there were some ways to look at some of these shorter ones, there might be some hints in what direction we're going.
So yeah, we can definitely look at, I can go back and subset on populations with asthma and diabetes and look at a 3-year window. But in general, not just this study, if you just look at the literature, there is no study which looks at impacts beyond 3 years. So this is, in some sense, this is the state of the art. And there are no studies which use electronic medical data to really look at health outcomes as you were interested in. So what most studies do is kind of look at these indicators for high-value services, indicators for problems such as use of ER and inpatient care, which is what we looked at, and just overall costs.
And certainly this is not a criticism that you did not do a good study. I think you did the best you could with the information you have. But part of the reason they're high value, right, is because people have done studies saying that they avert costs later on and decrease health. And so the fact that they went down is a bit disturbing and sort of indicates that in the long run that may cause that may cause more problems later on, but I appreciate that. Any other questions? Okay. Well, I want to thank both of you so much. Thank you very much for coming. And I also just want to acknowledge Assemblymember Cooley. Thank you for joining us as well. Thank you. Oh, that's right. Okay. So the next panel actually is the Legislative Analyst's Office. So welcome. And we have Nick Schroeder from the Senior Fiscal and Policy Analyst, and Marianne O'Malley, who I understand is here for questions, if she's here. Ollie. Why don't you come up and give you a better seat?
She has an injury. So.
Oh, okay. All right. You don't have a high deductible health plan. All right. Okay. Pay out of pocket. Okay. All right.
So we can't give her the boot.
You can't give her the boot. Okay.
Yeah, she already has that.
Well, welcome. Thank you.
Thank you. Good morning, chairs and members. My name is Nick Schroeder. I'm with the Legislative Analyst's Office. You should be receiving at this point a handout that we've produced. The purpose of this handout is really as an informational reference for the committee, and I'm not planning on speaking from it, so that's not talking notes. It's just information for you. The purpose of this hearing is to discuss high deductible health plans and consider them as an option, and to discuss the implications of adopting a high deductible health plan for as an option for public employees under PEMCA. And while PEMCA provides health insurance for local government employees as well as state employees, the focus of my presentation is going to be on the effect of offering this type of health plan to state employees. Generally, we're supportive of the idea of offering options of health plans to employees, including some sort of low-cost, high-deductible health plan, whether it be the high-deductible health plan that's established under federal law or some other low-cost plan. Before explaining our conclusion there, I'm first going to provide some background on PEMCA, as well as on how the state's costs for health benefits are derived, including the state's contribution formulas that we use. And then also talk about the reasoning that's been used in the recent past when these low-cost health plans have been suggested as an option in the past, including the governor's most recent 2015-16 proposal that's now before the legislature. So PEMCA provides health plans for state employees, both active and retired, and as well as active and retired employees of local agencies who choose to participate in the program. As the chair indicated in his opening remarks, it provides coverage to more than 1.3 million individuals, and that includes state and local employees and retirees and their families. And as the chair indicated, the CalPERS board serves as the plan administrator for those plans. And in that role, they negotiate the policies and premiums for the health plans that are offered under PEMCA. So now to talk about the state's contribution towards these health plans that are offered under PEMCA. The state's contribution is based on an average premium. And the first step in understanding this average is to know that it's based on the 4 most popular health plans. And so what the state does is it looks at the health premiums of the 4 most popular health plans, and it takes an average, a weighted average of those 4. And the state's contribution is based on that weighted average. And so going forward, I might just be saying the average premium, and what I mean is the weighted average of those 4 most popular health plans. So there are 2 types of categories of contributions that the state makes. It makes a formula-driven contribution as well as a dollar amount that's specified in Memoranda of Understanding. So first, on the formula-driven benefit, most active employees and all retired employees of the state receive the contribution based on this formula calculation. And these formulas are set up so that the state contributes a specified percentage of the average premium to cover the employee or the retiree, and then an additional percentage of the additional average cost to cover their family members. For active employees, the most common contribution is called the 80-80 formula, and under that formula, the state provides 80% of the average premium for the employee and 80% of the additional premium costs to cover their family members. For CSU employees as well as for retirees, the state's contribution is based on what's referred to as the 190 formula, and that's a more generous formula whereby the state provides 100% of the average premium cost for the active employee or for the retiree, and 90% for their dependents. In the case of retired state employees, they receive this maximum contribution, the maximum 190 available to them after working for the state for 20 years. They receive 50% of that benefit after working for the state for 10 years, and it's incrementally increases up to 100% after 20. So the second type of contribution is a dollar amount that's specified in an MOU. Typically, this is an amount where the dollar is actually listed in the MOU, and it's based on the calculation used under the formulas. So an example of this would be for Bargaining Unit 6 or correctional officers. In their MOU, they have a health benefit contribution that's equivalent to the 80/80 formula, and so the state makes its contribution based on that formula for the duration of the MOU. Once the MOU expires, the dollar amount that was last in the MOU for the last year of its effective date continues beyond the MOU. So the state's contribution doesn't necessarily increase or decrease, I suppose, as health costs change going forward. And so to understand the trend in health costs, the previous panel talked a little bit about it. Health costs have been growing significantly over the past couple decades, and this is really a trend that has been observed across all major employers and really anybody who's been purchasing health insurance across the nation. And for in most cases, most of this cost is attributable just to the general increase in healthcare costs. But for the state, there are a couple of reasons why the state pays what it does for health costs. One is that the state's workforce tends to be older and also have higher incidence of chronic conditions than the general working age population. So with regards to the last study, when they were talking about the 35 average, we would be higher than that as our average age of our average employee. And in addition, in the case of retiree health care, the number of retirees has also increased during this period, which has increased the state's costs. And this is really because of baby boomers retiring, as well as people living longer in their retirement. In 2015-16, the governor's budget assumes that the state will spend about $4.5 billion towards active and retiree health care. So in an effort to control these rising costs, there have been a number of initiatives that the legislature has considered to try to reduce healthcare costs. And one of these types of initiatives has been to offer a low-cost health plan, and these usually have some sort of high deductible element. Most recently, there's been the governor's 2015-16 proposal, but there was also in 2012-13 the core health plan that was going to be a low-cost, high-deductible health plan. And under the governor's proposal, he proposes to offer a high-deductible health plan as defined under the federal law, with a health savings account also as defined under the federal law to state employees under PEMCA. The goal of both of these types of plans is to reduce the state's costs by affecting that average premium cost. And so to do that, the goal would be that the premium for these high deductible plans would be low enough to significantly reduce the state's contribution, but also that the plan would be popular enough to attract enough people to make it one of the 4 most popular health plans. And so now back to our conclusion that it's reasonable to offer a high-deductible health plan to state employees. It's really based on the premise that choosing a health plan is a very personal decision for an individual. It's based on their personal and family health history. It's based on their age and a variety of other personal circumstances and needs. And because of that, we think that it makes sense to offer employees a wide range of options so that they can pick a plan that best fits their personal or family circumstances. And so because the state currently does not offer a low-cost or high-deductible plan, we think it does make sense to include that on the menu of options. That being said, we don't think that the state necessarily should assume that offering such a plan would result in savings for the state. We think that the fiscal effect of offering a high-deductible plan is really uncertain, and it depends on a variety of factors interacting with each other. And these factors include the popularity of the plan, whether or not it becomes one of the 4 most popular, whether there's an offsetting advantage that the state has to provide to employees, whether it be through employer contributions to a health savings account or through some other form of augmentation to their compensation elsewhere as an incentive to go into this new plan. And last, the other interaction would be the effect it has on other healthcare plans. And as the previous panel discussed, these types of plans likely are to be more attractive to younger, healthier individuals. And so to the extent that those individuals migrate from the existing plans, and in particular those plans that are currently included in the state's calculation of the contribution, it could have an effect on the premium cost of those plans and thereby increase the state's costs. So in conclusion, we're supportive of the idea of offering options, including a low-cost or high-deductible health plan to state employees, but we're not certain on the fiscal effect. At this time, I'll take questions.
Okay, thank you. All right, questions from? All right, yes, Senator Morrell.
Thank you very much for being here today. I have a question regarding other states on the HSA and the high deductible plans. Have you seen who are some of those states that have done this, and what type of savings has that been for the taxpayers?
We've looked at some studies that looked at how other employers were affected by offering a high deductible plan. And in the studies that we saw, it wasn't necessarily state employers, but public employers. When they offered these types of plans, they were not popular among their workforce. And so if you were to include, or if you were to assume that it would have a similar effect on the state, it wouldn't necessarily result in savings for the state.
Any other questions? Okay, I actually just had a question. So you mentioned that certainly one piece you said in terms of giving people more options, but in terms of trying to figure out the state contribution, certainly we heard from the previous panel. One is that you'd have a shift, right? People are healthier, probably be more attractive. So that's going to raise the premiums of the other more traditional plans. We heard 5% if there was a 20% shift. From what you said, I guess the hope from perhaps, I won't say the governor's office, but the proposers was that if it rose to the top 4, that it would then drag down the average. Is that but at the same time, we heard that depending on what the package was, right? The previous panel talked about, well, actually, let's carve the medications out, let's carve this out, let's put in a higher employer contribution. And you just mentioned that looking at some of these public employers, that they didn't see much savings. So it sounds to me like it's at least for the state. So aside from the health issues and health outcomes, which obviously I think many of us care about, it doesn't sound like it's, even if it managed to work its way, you'd have to provide so many incentives, it really wouldn't be, I mean, I realize it's uncertain, but I'm not hearing from you that, boy, this thing's really going to be a winner in terms of, and actually I'm also concerned that if you came up with a cheap plan that rises to the top 4, what you're really doing is you're defunding the health care for people who need more healthcare services who would stick to the traditional plan. Would that be the case?
I think that it really depends on the structure of the plan, and it depends on what type of incentive the state offered to employees as a way to attract them into the plan, as to whether it really does migrate all of the healthier younger people away from the existing plans. If you created the right incentive structure, maybe it would attract other types of people and not necessarily have the selection bias, similar to what the previous panel had discussed. So I think it really depends on the structure of the program.
And, yes, Senator.
Just a clarifying question from earlier. You guys studied probably the short term, but also a long term. Did you extrapolate it out like 10 or 15 years? Because the short term seems like it would cost the state more, but the long term, Seems like there would be a flip and a cost savings to actually taxpayers. Do you have any information on that?
We haven't really looked at the long-term effect for the state, and as the previous panel indicated, it's potential. There's a lot of long-term effects that this might have in terms of health outcomes and things that we just can't predict, and it's really difficult to say what effect it would have in the long term.
We're not sure what effect it will have in the short term. So extrapolating out
Yes.
further is even more uncertain. Frankly, this could be an increased cost to the state. It could be a decreased cost to the state.
Just a thought, though. I mean, it seems like you're going to have to some way forecast those numbers. If not, you're just, I mean, you know, you're flying blind. I mean, that's something you have to do. Am I not correct on that?
Well, at this point, we don't have enough information to really forecast it because we don't know what the plan design would look like. We don't know what incentive would be provided. We don't know really which employees would be attracted to the plan. So it's really difficult to say with any level of certainty what effect it would have.
And I would say is we just had one of the researchers who did the most detailed long-term, even at 3 years, study of high deductible health plans presenting before us, who indicated that the savings decreased over time, right? 3 years, it shrank. There wasn't, but costs indicated that people were cutting back on medication for long-term care, cutting back on lab tests that they may need to prevent long-term sequelae. To me, that actually seems to be hinting to me, as a health services researcher, that we're looking at increased costs in the future, not decreased costs, because even in the 3 years you saw decreased savings, went from 18% down to 8%, and then so who knows what comes after that. But we're also looking at people deferring care or services that would actually lead to potentially higher healthcare service demands later on, and especially if we're not only paying for employees, we're paying for retiree health. That to me is pretty concerning in terms of trying to project what our long-term costs are. I realize that without the details, it's impossible to do that. But I mean, we just heard from one of the most, the most detailed studies of these plans right here earlier. So, okay. Any other questions? Yes, Senator Rabanta. Okay. Actually, Mr. Cooley, why don't you go first? Well, you have the chairs go last.
I was just going to make the observation that at some point it would be perhaps interesting to ask staff to reach out to the American Academy of Pediatrics, find that area within the actuarial field where you have folks who specialize in these sorts of issues, dealing with the long time horizon, the variation in the population. Folks in that line of work are designed to kind of think through a lot of the possible scenarios and ramifications. We know that in our business, the very workforce that makes the attractiveness of these plans may be marginal. Ultimately, we need to be thinking about succession planning and state employment, and so kind of understand how plans relate to people's choice of careers. I mean, there's a lot of facets that we might find that some actuarial folks might shed some light on some of the dimensions of the issue. But I definitely think that's something that chairs and staff could pursue initially.
Thank you. Senator Rabanta.
I want to thank you for your presentation and being here today. And just to sort of clarify what I think the LAO's position is, it sounds like your position is that a high deductible health plan might be appropriate simply based on the idea that the more options, the better. But if you did have a particular goal to save costs or provide better health care outcomes, then a high deductible health plan would not necessarily achieve those goals. Is that accurate?
I think that's an accurate summarization. It's that in general, we think it's a good idea to provide options to employees so that they can make plans or choose plans that best fit their needs. That being said, depending on the goal of offering that plan, if the goal is to achieve savings, that might not occur. But if the goal is to provide options, then yeah, that's a great idea.
Okay. Thank you. I just also want to state that my understanding is that CalPERS now has the authority to pursue a high deductible health plan if they wish, and they've considered it, but have specifically declined because of the adverse selection potential that has been, that you've described and others have discussed, with the younger, healthier employees migrating to the high deductible health plan, and the older, sicker members staying with the traditional plans, and thereby raising the cost of those plans. So, this has been an area that's where we've considered the options, where the information's been on the table, and there have been deliberate, intentional decisions not to go in this direction because of the unlikelihood of any savings. So, we're here at the threshold of that bridge again with the proposal by the governor, but I think the same concerns continue to exist. But thank you for being here again.
Any other questions? Seeing none, I want to thank you so much for being here, and I think actually, Chair Bonta, your remarks are quite appropriate for bringing up our next panel member, who's Ann Boynton from CalPERS, who's Deputy Executive Officer of Benefits Program Policy and Planning. And I want to, again, thank you, Elio. Welcome, Ms. Boynton.
I had to do a health check.
There we go.